People. Is this recording? Oh, yes it is. How you like that? Did you get sick when I moved that? Okay, so I was actually excited, not about this actual text. Actually, it's not a bad text. Chapter 13, pragmatic issues. No, pragmatic issues. And why did I care about this so much? Because my post-MSW, immediate post-MSW experience was program evaluation. And I did some of that while I was working on my MSW and became the co-evaluator for a program that really shaped my ideas about what I needed to know more about and what some of the challenges were, and what I wanted to do different next time. And it was really a big motivator, I think, in the end, in sending me back to school to get my PhD in social work. So that's part of why it was really important to me. And there's just a lot of things to consider. So treatment fidelity, big word, what the heck does it mean? Your textbook talks about 3 different things. It talks about, I'm looking right at your textbook. Okay, so the treatment adherence. So are you really doing what you said you were going to do? If there's supposed to be weekly group sessions, are those really happening? So that's an example out of my personal experience. Is that, or are you really doing what you said you're going to do? Competence would refer to things like, the skill of the interviewers. A different program project I worked with, folks were interviewing kids and their families in the child welfare system, and some people simply had more skill in interviewing. They had more experience. So my guess is they probably were able to tease out more information. And then the other thing with treatment fidelity is treatment differentiation. And without even knowing these terms, my guess is that you would know if you've got a treatment group who's receiving, experimental group receiving this new treatment, and a control group receiving, say, the old treatment, and the control group starts receiving some of the same stuff this treatment group is, that's a problem, okay? And so that's something that I experienced, is that our control group started looking like our treatment group, because the control group social workers started giving more stuff to control group kids, which seems great, but it totally messes up your, research design. So those are some things to think about. What else do I want to tell you about? So on page 319, there's a checklist for ensuring treatment fidelity. And I kind of want to throw up when I read all this, because it's a lot. And the thing that I keep thinking about is that rigorous program evaluation is a lot of work. But still, I want you to know this stuff. I think these are things that I kind of figured out. I think I did the best that I could. But there's some things that I get to do different, now. And so one of them they point out is that all service providers are equipped with a treatment manual. And that's something you will see over and over again, or you will read about manualized treatment. So that's not always the case. So if you don't have a treatment manual, to still develop some really clear protocols about what needs to happen, so that everybody can have that document. Something else that stood out to me was this periodic ongoing training. So one thing I had to do was train them in data collection, and to continue to do that, to remind people of how to collect the information. Because what I found at some point is they weren't, I could tell the data was wrong. And part of the challenge is I wasn't there all the time, and I should have been there more, in hindsight. Something else from this checklist about ensuring treatment fidelity: supervisors meet regularly with service providers to discuss progress and problems. And that's part of why, if you're the evaluator, and my experience has been more as the external evaluator. So say I'm working at a university like here, and I'm actually have a piece of the grant. I'm the evaluator for, say, at a state agency, a project they have. But to actually be present and communicate with people. Again, a lot of it's about communication, making sure we're all on the same page with what's supposed to be happening. And then to continuously monitor the new intervention. And some of that means you're present physically, and when you're not, you have people that are letting you know what's going on. And then another thing that's really important is how do you correct the problems if they occur, with treatment content or whatever it is. And something also that's really important is that you don't change how you select or you screen participants. You decide on how folks are going to be referred, and you stick to that. Okay, so those are just some things from that checklist for ensuring treatment fidelity. It is. It's like it was comforting and depressing all at the same time to read this chapter, because it just reminded me I'm not alone. These are challenges everybody faces. And so when I look on page 320, there is another nice little box. Thank you, Royse and colleagues, about anticipating and neutralizing fidelity problems. And so I just thought I would talk about a couple that stood out to me just based on my experience. And you can read all these to see. One thing they talk about is provider protocol or program drift. And so part of how to reduce that is to make sure that the program doesn't start to change, which I think I saw happen. One suggestion they make is a brief questionnaire on how the intervention is going, or conduct interview with staff and clients. And so that would have been, good in hindsight to do. And then something else that gets talked about here, and this is box 13 too, minimize contamination between control and treatment conditions. And so so one of the suggestions they have is how to minimize it. They say is to conduct interviews with clients in the control condition to ensure they didn't receive the new intervention. And so what I saw happen was that these kids that were in the control group were receiving some of the same services as the experimental group. So inherently, maybe that's not bad. Maybe it helped those kids. But then what it means is your control group isn't your control group anymore. There's some version of the treatment group. So that's the issue. I'm looking at the next page.